Welcome. Welcome to our session, Approaches to Addressing Social Determinants of Health in Healthcare. We know that health is more than just healthcare. And even though health is more than just healthcare, the access to healthcare through those social determinants is a key and important factor, a factor that we have seen ever more present and integral to our society this past year with the pandemic of COVID-19. I'm excited today for our esteemed panel and all of the papers that we will be discussing. I will introduce each of our speakers and what we will be talking about over the course of the panel. They will each then present their papers, and we will come back for a discussion with one another, and hopefully you will be able to join in on the chat as well. So we know that the social determinants of health impact us all, but when those social determinants of health have adverse impacts, they create more utilization of our healthcare system, as well as higher chronic disease rates. Dr. Catherine Schiavone and her colleagues will walk us through their cross-sectional study with patients from February 2019 to 2020, just prior to our pandemic announcement. They will talk about the prevalence of social risk and social needs in their paper, Prevalence of Social Risk and Social Needs in Medicaid Accountable Care Organizations. Next, we know that the setting matters. The setting matters not only in where we live, work, play, and worship in our social determinants of health, but also in the experiences that we have within our healthcare system. And in experiences and perspectives on adapting new practices for social needs, we will hear from Dr. Eileen Namey and her colleagues as they will discuss tools and practices that are critical in the community context and the setting. People operate within systems, and clinicians are often trained to operate within their specific system of healthcare and healthcare utilization. We know that the field is widening though, and those clinicians are needing to grapple with healthcare happening outside of the walls of those spaces in which clinicians operate. Dr. Randy Burson, we're just going to welcome you right on in. But Dr. Randall Burson and his colleagues will be discussing the implications of reimagining the social in education and practice through their longitudinal study. And it'll be really interesting as we hear through this qualitative assessment of the structural practices and the structural competencies that are needed within the education of our clinicians. And finally, Dr. David Walker and colleagues in their paper, Utilization Patterns and a Clinic-Based Food Referral Programs, will give us a voice from what all of this means in practice, from the social risk and the social needs analysis, how that works within clinical settings, who is trained to be able to do this, and then what does that look like when patients really need to use the referrals of the particular social needs or social determinants that they have. And so in this paper, in this discussion, Dr. Walker will be talking with us about patients' needs in that community context and the clinicians that were trained in this Mid-Ohio Pharmacy Food Program. Each of these speakers has such a fantastic and a phenomenal view on how social determinants are a complex and a multifaceted dynamic system that we all need to be working together on. Academia, managed care organizations, as well as our government partners. So I will turn it over now to Dr. Schiavone.
Okay. Hi, everyone. I'm Catherine Schiavone. I'm a population health fellow at Mass General Brigham in Boston. and an internal medicine and pediatrics primary care physician at Mass General Hospital. And I'm going to be talking about the prevalence of social risk and social need in our Medicaid accountable care organization. So social determinants of health are defined by the World Health Organization as the conditions in which people are born, grow, live, work, and age, and the larger set of forces and systems that shape the conditions of life. And those factors can be either positive or negative and can include both individual and neighborhood factors. And so here we talk specifically about adverse social determinants of health, meaning those social conditions that negatively impact people's health and health outcomes. And there's now a substantial body of literature showing that adverse social determinants of health can lead to higher chronic disease prevalence, as well as worse chronic disease control, both in adults and children, and higher healthcare utilization. So there has been increasing interest both by health systems and payers, particularly in the public sector, to screen patients for social determinants of health in order to more effectively address these factors. In a social determinants of health screening, that can include two categories. It can include screening for social risk or the specific adverse social conditions associated with poor health. So for instance, housing instability or food insecurity, and for social need or the request for assistance based on an individual's priority. So someone asking for assistance with food. And those are the terms we'll be using in this paper and presentation to differentiate those different areas within an SDOH screening. So at Mass General Brigham, we are a Medicaid accountable care organization, which means that we have a value-based contract with Massachusetts Medicaid or Mass Health to be responsible for the spending, quality, and care coordination of our patient population. Currently, that is about 126,000 patients, about half of which are pediatric under age 18. And as part of that ACO contract, we are required to screen our patient population at least once a year for adverse social determinants of health. So for some background, Mass General Brigham, or MGB, ACO has a varied and diverse physician network. We include both large and small physician practices who are both employed or affiliates of the system, and we are across the state of Massachusetts, so including both urban, suburban, and rural locations. The network has 2 academic medical centers as well as multiple community physician organizations. So that includes Brigham and Women's Hospital and Massachusetts General Hospital. And we also have 5 federally funded community health centers that are part of our system. So to screen for adverse SDOH, this is done in the primary care setting in our system, and patients can fill out an SDOH screener on the patient portal through our electronic medical record, and that's available up to 14 days before their visit, or in a tablet that's provided to them in the waiting room during a routine primary care visit. And those screeners are available both in English and Spanish. Our social determinants of health screening involves 13 questions. We screen for 8 domains of social risk using standard screening questions. So this includes 2 questions for food using the hunger vital signs, 3 questions for housing, asking about both current housing and housing stability, as well as questions about medication affordability, transportation, utilities, child or family care, education, and employment. And then at the end of the survey, there's a question that asks about social need, stating, would you like more information today about any of the following topics? And then includes the 8 domains that were screened for as part of our social risk screening. So although we are screening for both social risk and social need, the overlap between patient-reported social risk and social need is not well understood. So in this survey, we wanted to compare the prevalence of social risk and social need in primary care in this Medicaid ACO population, and then to identify patient factors that were associated with differential prevalence of social risk and social need. This was a cross-sectional study of patient responses to SDOH screening and included 151 primary care practices in the MGB Medicaid ACO. As Brandy mentioned, this took place between February 2019 and February 2020. And we chose that date range for our study because it was about a year after the screening launched for our Medicaid ACO. So we felt that by this point, it would have been well implemented and at kind of a steady state in our practices. But before COVID-19, where there were several changes to primary care operations and screening. And we included patients in this study who had at least 11 months of enrollment in Medicaid during the 13-month period of our study. So as part of this, we looked at descriptive statistics of patient responses. We stratified by race, ethnicity, and language, and then compared patient groups using a chi-square test. So in this study population, there were 27,500 individuals who completed 30,820 screenings. And some individuals may have been screened more than once if their 12 months were within that 13-month period, or for some pediatric patients, they are screened more than once during a year if they have more than one well-child visit. And this was a mixed adult and pediatric population, with about 55% of our respondents who were caregivers of pediatric patients. Overall, 78% of our respondents spoke English, 15% spoke Spanish, and 4% spoke another language. Sometimes an interpreter will go through the screener with the patient. And then for race and ethnicity, at the time these responses were documented, our electronic medical record lists race and ethnicity as a single field. So that is what we used in our study to be consistent with how patients self-identified at the time of registration. And in our study population, 34% of patients identified as Hispanic or Latino, 11% as non-Hispanic, Black, or African American, 47% as non-Hispanic white, and then 8% as non-Hispanic and the race category other. Of the 30,820 screenings, we saw that almost half, 44.6% of patients reported at least one social risk, so screened positive on a screening question. And almost 10% of those patients were positive for 3 or more risks. We saw that 19% of patients were positive for social need, so indicated they would like more information or assistance on a topic. And then 35% of patients were positive for both social risk and social need. Interestingly, we saw that 6% of patients were positive for social need, so did ask for assistance, but screened negative on our screening questions for social risk. We next looked at different patient populations in terms of race, ethnicity, and language to see if the prevalence of social risk, social need, or both were different in these patient groups. And among our 4,407 patients who spoke Spanish, we saw that 51% had a positive social risk, 29% indicated social need, 48% had both, and 9.2% asked for more information or assistance while screening negative for social risk, so had social need only. And this was substantially higher, was significantly higher than our 24,323 patients who spoke English. And then in our race and ethnicity groups, we saw that those patients who identified as Hispanic or non-Hispanic Black had significantly higher proportions of reported social risk, social need, and also who reported social need in the absence of social risk. And that was significantly higher than in our non-Hispanic white patient group. So the most important finding coming out of this for us was seeing that social need and social risk are really distinct. And although there is an overlap between these factors, it's not a complete overlap. And that screening for both types of patient-reported measures identifies different populations of patients with adverse SDOH. In particular, it was important to note that Hispanic, non-Hispanic, Black, and Spanish-speaking patients reported significantly more social risk and social need than non-Hispanic, white, and English-speaking patients, respectively, and that these groups more often reported social need while screening negative for social risk. So this leads to several important implications for policy and clinical practice. That screening for social risk alone with validated tools does not necessarily identify all patients with adverse social determinants of health. That when we screen for both risk and need, we identify more patients with adverse SDOH, particularly among groups of patients who experience systemic racism and health disparities. And so when health systems or payers such as Medicaid are implementing screening tools, they should consider implementing tools that incorporate both social risk as well as social need. And that doing so would allow for more inclusive identification for adverse SDOH, which would provide us a greater opportunity to offer intervention to address those adverse conditions and mitigate their negative health impacts. Thank you so much.
Hi, everyone. I'm Eileen Namey. I'm an assistant professor of population health at the University of Texas System and the University of Texas at Tyler. And today I am going to share some findings from a recent study, safety net clinics in Texas, related to their work to address the social needs of their patients. I'm going to start first by just quickly situating the focus of this project in the larger context of social determinants of health work. So we wanted to learn about efforts to address individuals' non-medical health impacting needs. So some are calling this work social needs targeted care in order to distinguish it from the more upstream work that is necessary to create the conditions for health in communities. So I want to start also by mentioning that we know that addressing patients' social needs is not a fundamentally new practice, particularly for safety net clinics. Safety net clinics have always recognized that their patients have these non-healthcare needs that impact their health. They've made referrals. Sometimes they have in-house resources, and then hope that their patients are able to access those resources and get their needs met. But the current push or movement is for clinics to take a more systematic approach to this work, and to do so in partnership with community organizations. And so to this end, there's been several new tools that have emerged. First, standardized screening tools that could be integrated into electronic health records and incorporated into the clinic workflow process to collect data on their patient social needs. And then more recently, online community resource referral platforms that allow participating organizations to share information securely and allow clinics to make referrals with greater confidence in the services that they'll be receiving, and close the loop on that referral to know whether their patients received the needed assistance. So we wanted to get a sense of what is happening on the ground in Texas safety net settings, and hear the perspectives of clinical decision makers and care providers. So the purpose of this is a qualitative study to describe the current practice of social needs targeted care in 3 safety net clinics in Texas, and identify facilitators and barriers to adopting these new tools and practices. So we conducted interviews with administrators, providers, and staff. The clinics that we included had variation in the extent of adoption of these new tools and practices and different approaches to social needs targeted care. And we conducted these interviews between November 2019 and March 2020. So the first case study I'm going to share with you is of a rural FQHC, 5 clinics in 2 counties in Southeast Texas. So this organization works to connect its patients with needed social services in much the same way it has since its inception. Social needs are identified through routine care interactions. They don't have a standardized screening tool, and referrals are given to the patient directly. Patients are encouraged to follow up with the referral themselves. The staff say that they were very familiar with the available community resources. The CEO told me, there isn't a social service agency that we don't partner with in some way. We know all of them and we work with all of them. Now, shortly before our interview, the CEO had met with a regional health information exchange that was interested in organizing community partners to use a referral platform. And the CEO told me she had some skepticism or had a hesitancy about the relevance of such a platform in her community. And what she told me was, if we're going to get money, that's just not the way to invest it. You're talking about working with people in a rural community. Hardly any of the social service agencies here have the technology or the capacity to do this. They're keeping track by paper if they keep track at all. Also, recently, the organization had incorporated a social needs screening tool into their EHR. The CEO told me, we know it's coming, so we went ahead and reached out. Our electronic health record provider had already made the decision on the tool, so we simply asked them to upload it into our system. She's still not sure if or how they will use this tool, and she expressed some concerns about privacy related to collecting social needs data and also embedding it into the EHR. However, she did see some potential value for collecting the data. She told me, one of the challenges we have had is for local government to openly admit that there are problems in the community. So any opportunity to collect valid data and present that is going to be invaluable to the people that live here. The next case study is an independent pediatric clinic that serves a mid-sized community in Northeast Texas. So this clinic is interesting in that work to address social needs actually predated their clinical services. They began as a food pantry and a clothes closet before they started their pediatric clinic. About 3 years ago, they had started screening formally for food insecurity using a standard tool, the Hunger Vital Sign. And about 2 years ago, they started using a broader social determinants of health screening tool that they based on existing tools, but tailored for their own particular needs. Parents are asked to complete the social needs screener at new patient annual visits while in the waiting room. The provider reviews the results with the family and then shares some needs-specific resource sheets with patients. And for families with urgent needs, the providers will refer the family to the clinic's licensed clinical social worker or the social work intern. And that person may provide some counseling or more hands-on assistance in connecting with services. So in that sense, it's similar to our first case study, but maybe with the addition of that social needs screener. Now, the clinic, their biggest focus, however, has been on addressing food insecurity. So in addition to the food pantry, they have a partnership with the food bank that includes healthy food boxes, nutrition education, and assistance of enrolling in SNAP or WIC. And the pediatrician I spoke with recognized that food insecurity is never a standalone issue, but she told me, my hope is that this relieves some of that strain and they're able to utilize more of their own personal family resources towards one of the other needs that I don't have as great of community-based organization resources for, like housing. This clinic does not have access to a referral platform, and the pediatrician saw benefits of such a tool. She believed that establishing a referral platform would require leadership of a large regional institution. The small clinic isn't a big enough player. To get a bunch of nonprofits and social service agencies to uptake an electronic platform and to change their workflow, I think it would require buy-in of one of the regional hospital systems. She also had this to say about her perspective on the companies providing these platforms. Maybe this is because I've lived in the world of nonprofit health clinics for a long time, but I'm really skeptical of platforms like some of the for-profit platforms that charge for organizations to use them. Because I just think, how do we get uptake of that when we've got nonprofits that are working on this shoestring budget and clinics that are working on a shoestring? So the third case study, and the last one I'm going to talk about, is actually the only clinic system that we were able to find that was up and running with a systematic screening and a closed loop referral process. This is a 12 clinic FQHC that serves both rural and mid-sized communities. And they began this work similar to the second clinic I mentioned around 2017, after hearing the calls for clinics to do more to address social determinants of health and recognizing their own patients' needs. And the leadership committed to address patients' social needs in a more systematic way. They began looking for options for standardized screening tools and referral platforms. So in addition to the leadership commitment, the two other key catalysts were, one, they received a 2018 grant from HRSA for information technology improvements. And this was not connected to the referral platform, but they were able to apply it for that purpose. And then second, a partnership with a local United Way. So the chief administrative officer told me, we just happened to reach out to the United Way when they were looking to replace their 211 system to address community needs. They invited some of their grantee partners to come in and look at referral platforms. We put up the implementation costs, they put up the training costs. It's been a great partnership, and we would not have been able to create a network without the United Way. So by the fall of 2019, when I spoke with them, the referral platform was operational. The partners had been trained on using the screening tools and the platform, and the staff felt positively about this new system, that it was an improvement over previous methods of providing referrals, particularly that the referrals were well vetted and there was accountability. When the care coordinator told me, in the past we would refer patients, but we would never hear back whether they actually got the assistance. Now we can actually track it in the system and everyone's accountable. Now, according to the chief administrative officer, achieving the goal of all patients being routinely screened and having enough referral options to address identified needs will take some time. It will take further investments and additional partnerships. She said, I can't dedicate as much of my time to making sure it's pushed through as I would like. So it's all about staffing. It's all about the money to pay another employee, the amount of money that we need to really make the process happen. So I want to wrap up with just sharing a little bit of across the 3 interviews, some of those motivators or facilitators for adopting these new practices. There was a general sense that there's value there's a motivation to generate data to help inform community action. A sense that there was some accountability that the referral platforms provided. Perhaps a way of burnout prevention, that when providers are able to address their patients' social needs, they have greater job satisfaction. And a recognition that maybe they can't address all social needs, but if they can help with one, that can help relieve some of the pressure on patients. Some of the facilitators having funds to cover the startup costs and having an influential community partner to work with. This is particularly relevant for the community resource referral platforms. Some of the barriers or some of the perceived drawbacks, as I mentioned, there's some concern around data privacy, confidentiality, and also a blurring of what are the appropriate roles and responsibilities of healthcare. Of course, limited staff time, lack of reimbursement for the care coordination that's required. And importantly, the limitations of the social service organizations to absorb referrals and also to participate in something as sophisticated as a community resource referral platform. And then lastly, some skepticism about the motives of some of these platform providers that have proliferated in great numbers across in the US. Briefly, limitations, this is 3 clinics. There are many more examples out there of how things are being done on the ground. And that also, because we completed these interviews prior to COVID, certainly many things have changed and been impacted as a result of COVID. And I want to thank you all for listening and our supporters and partners.
Hello, my name is Randy Burson. I am an MD PhD student at the University of Pennsylvania. And along with my colleagues, Olivia Familucci and Justin Clapp, I'm going to be presenting our presentation, Reimagining the Social and Education in Practice, a qualitative study of perceptions of structural competency in medicine. So as the purpose of this panel has been discussed today, clinicians are being called on to recognize and act on the social systems that influence health and healthcare in our society. And increasingly, they're being called to do that in new and innovative ways, as well as within new settings. Health professional schools in particular are a particular and privileged position where prior frameworks like cultural competency are being adapted to help clinicians navigate intersections of medicine and society and the way that those intersections are changing. This leads us to ask questions: how do physicians and medical students understand and communicate social factors relevant to health and care? And how do they imagine responding to these factors in the clinic? In particular, we're looking at a shift in the curriculum at one medical school from a cultural competency to a structural competency model. The shift is coming out of growing critiques and concern about cultural competency, despite it being a prominent framework, so much so that it's actually within the LCME accreditation requirements. There have been growing recognition that as a framework, it can be reductive or essentializing of patients. It can be used in ways that are synonymous with race, ethnicity, or other categories that other the patient. It can be reduced to a list of do's and don'ts as opposed to an ongoing conversation attempting to develop a deeper understanding of how social factors affect a patient. And importantly, it often fails to recognize that medicine itself is a cultural system. There have been a number of frameworks that have tried to address these limitations of cultural competency, including cultural humility and cultural responsiveness. However, we're going to focus today on structural competency, which is a emerging framework presented by social scientists, physicians, that really seeks to reposition symptoms and diseases as the, quote, downstream implications of upstream structures. The understanding of social structures advanced by structural competency draws on multiple literatures, including anthropological literature, sociological and stigma research, and public health, as well as a number of other critical cultural studies. Because of the multiple literatures, we also tend to offer some examples of how these scholars are operationalizing the term structure. In particular, the examples they give are healthcare and food delivery systems, zoning laws, urban and rural infrastructures, medicalization as a process, and even the very definitions of health and illness themselves. This leads us to the objectives for our study. First, to evaluate perceptions and attitudes of physicians and medical students as they learn and teach about social factors and health equity in a required first-year medical school course. Wanted to explore how physicians and medical students interpret, engage with, and use the emerging framework of structural competency in clinical practice. This study is situated within the first semester, first-year course, Introduction to Medicine and Society. It's comprised of 12 modules that address a range of factors from structural competency, as we're mentioning here, to narratives of illness and suffering, race, gender, class, as well as physician advocacy and the medical gaze and medical culture. We're focusing specifically on structural competency module, and we were conducting it as part of a larger longitudinal evaluation of this course. However, today I'm only going to be presenting a sub-analysis of this. You can see in the module itself here, there was pre-readings and a reflection exercise of kind of two key texts, one of which is a critique of cultural competency by Arthur Kleinman and Pete Benson, as well as the foundational document that sets out the framework for structural competency. It was followed by a plenary lecture, as well as a small group discussion. The longitudinal qualitative and project that we undertook had 3 interview time points. One was prior to this module, trying to understand the place of teaching about social factors in medical schools. The next was after the module, was an evaluation of the module and teaching itself. And then finally, the sub-analysis we're presenting here today is a follow-up interview that really is interested in talking about how participants were planning to operationalize the learning that they had engaged in over the course of the semester. We're working across here actually a couple of different participants, attending physician and fourth-year student facilitators who were teaching and leading the course and the discussions, as well as the first-year students themselves. And the reason we did this is to kind of get some variation, as well as different perspectives in relationship to practice, as well as education. We conducted a pretty conventional qualitative study. Each of these consisted of semi-structured interviews via Zoom with my colleague Olivia and I, as well as standard coding process. We interviewed 5 attending physicians, 3 in internal medicine, 2 in surgery, and 2 in pediatrics, as well as 8 fourth-year student facilitators and 7 first-year students. Apologies for the doorbell. We had a slight overrepresentation of white non-Hispanic participants and a slight underrepresentation of Asian participants compared to the class as a whole, as well as the Black, non-Hispanic, and white Hispanic participants were roughly representative for the class that we interviewed, as well as a slight majority of women participants. Turning to the results, we first wanted to try to understand, because the literature draws on multiple definitions of structure and understandings of structure, how the participants in our study were understanding it. Almost ubiquitously, they understand it as beyond the individual, and that these structures act on both patients and the clinicians. However, you'll notice the asterisk here. This actually indicates that, especially in the earlier interviews, a lot of our participants did not initially discuss the ways that structure affected them as clinicians, and it wasn't until after the interview and kind of further conversations that they began to discuss how they themselves are also within and implicated by structure. Additionally, it was used in a way, the term was used in a way that was often synonymous as well as intrinsic to other terms, including society, infrastructure, institutions, organizations, and social. And finally, the kind of idea of structure is that it was being built or constructed. Often it was discussed as being built or constructed to harm some, but a number of participants also recognized that that harm to some is also a benefit to others. And so that was a theme that came out, was that it wasn't just kind of unidirectional, but actually there is both sides of this coin here. As well as a long list of examples of structure that were listed, I'm going to just talk about the top examples: insurance, economic structures, racism, healthcare access, culture itself was listed as a structure actually, as well as things like healthy food and neighborhoods. The scope of the ways our participants imagined acting on structures as a kind of entity were in a number of ways. First, there was an awareness, our participants universally understood that an awareness of structural factors as affecting patient care was necessary. However, our participants, there was some variation in how they thought physicians should go about addressing those structures. Some, particularly the younger participants, a few younger participants, took a kind of stay in your lane approach for physicians, while others saw it as an intrinsic part of the job to address structural factors in providing patient care. The levels of action in which the participants discussed using structural competency were everything from the patient-physician dyad through the medical team, the healthcare system, and even at levels of community action. And I'll talk a little bit more about kind of how this is playing out at different levels. And finally, some of the limitations of acting on structure. Our participants discussed how medical culture and hierarchy limited their own ability to address social factors in the clinic. A quote from a student facilitator is talking about how time, energy, money, and systems that work us to the bone limit physicians' abilities to be structurally competent. Talking a little bit about the various levels in which the participants saw themselves as acting, they recognized the importance of multidisciplinary teams in providing skill sets, resources, and knowledge to address social factors that affected their patients in the clinic. And referral was a key practice in how individual participants saw themselves as being able to be structurally competent, required that they relied on other people to be part of that team and to be part of the multidisciplinary approach to addressing those factors. It wasn't something they could do alone. One student facilitator quote says, "When I feel like I'm in a position to do something about it, like talk to a social worker and see if we could figure out how XYZ service for this patient, when I feel like I or someone else on the team is able to mobilize resources to, at least in that moment, help the patient, I think that structure doesn't feel as insurmountable." I mentioned it also previously that one of the levels of action was this community organization as a potential resource and a potential way of addressing these social factors. And participants presented themselves often as outside of that community, which is interestingly enough, and we can talk about that more in the Q&A, but this idea that participants often refer to that as outside of both their scope of control, but also outside of themselves, despite often living in the community. The next theme that we wanted to touch on was at the level, mostly the patient-physician relationship and the patient-physician dyad. Structural competency was seen as increasing the awareness of participants and increased awareness of the structures affecting participants' lives or patients' lives. That this increased awareness had some implications for how they were able to relate to their patients, but often in presenting and discussing how structural competency helped them, the patients that they imagined and discussed helping were often portrayed as marginalized or disadvantaged almost exclusively. Nevertheless, that structural competency helped them be more empathetic and non-judgmental in their communication, ask more informed and open-ended questions, and remove shame or blame from certain conversations that might be stigmatizing. And ultimately, an improved communication enhanced physicians' abilities to relate to patients. Finally, we noticed a range of emotional responses in addition to the intellectual ones, feelings from being empowered and hopeful to powerless, futile, and overwhelmed, and the concern that ultimately long-term inability to address structure would lead to burnout. For the sake of time, I'm going to skip this quote, but the take-home point is that humility is an alternative to those feelings of being overwhelmed. In conclusion, reimagining the social or the cultural and structural terms has both promises and pitfalls. Structural competency as a framework can be used to improve patient-physician communication as our participants imagine it. However, in that imagining and in that use of structural competency for them, that really recenters the patient-physician dyad as the space where social factors are taken into account. And it really requires this other level, which is this multidisciplinary teamwork model that is both necessary and able to address social needs. The participants, however, in talking about those social needs, often portray themselves as outside of the communities in which they're working, and also presented medicine as itself separate from society. And so that in some ways is kind of reinforcing the same critiques of cultural competency as it being without, medicine as a culture of no culture. In this case, it being medicine as a structure of no structure in a way. Finally, there's uncertainty about structural competency as a concept and how to act on structure. Participants often thought that they were acting in or around structures rather than on them. And finally, this question of who is the patient who needs structural competency is an essential one. Thinking about, again, the critiques of cultural competency, some of this study presents a worry that without kind of critical attention to those prior pitfalls, we may actually be reproducing the certain essentializing or reductive categories of patients in pedagogy. Finally, structure as itself is helpful, but is at the moment used in a way that is almost totalizing, that it can be unclear. Finally, we want to pay attention to the previously unacknowledged emotional responses and the practical implications they have alongside the process of learning. So moving forward, there's opportunities for connections to communication skills and social needs response initiatives across the medical school curriculum. And structural competency needs greater conceptual clarity and specificity on how to address social concerns, as well as an awareness of the social and cultural environment of medicine and medical education itself needs to be brought to the fore in how we talk about these matters. So thank you very much.
Good afternoon. My name is Daniel Walker, and I'm assistant professor in the Department of Family and Community Medicine at The Ohio State University. And I'm pleased to present this study entitled Utilization of a Clinic-Based Food Referral Program, Lessons from the Mid-Ohio Pharmacy. I want to begin by thanking my co-authors. This work really is a team effort, and I'm really grateful for their assistance and support. And I want to acknowledge our funder, the Crisafi Monti Foundation. So to begin, food insecurity, which is defined as the inability to afford and access nutritionally adequate food on a consistent basis, can contribute to ongoing health concerns, particularly for chronic conditions such as obesity, diabetes, and hypertension. Food insecurity, however, is one of the more tractable non-medical health-related social needs that the healthcare system may have some solutions in place to be able to address and support. There are increasingly some clinic-based food referral programs that connect food insecure patients from a clinic setting to food resources available in the community. These programs really are premised on the idea that connecting patients to food in the community can provide a primary or a secondary source of food for both individual patients as well as their families, and that this connection may be able to operate as a food as medicine or as a food as prevention resource. Prior evaluations of food referral programs have shown that they can improve access to food, as well as some other health-related non-medical social needs, such as housing and medication assistance. This work has also shown that though the evidence is limited, they can be successful at improving healthcare outcomes and reducing healthcare-related costs. Given that, this research really addresses the particular gap in prior work that has kind of not focused on the implementation process of these food referral programs, and trying to understand how these programs work and what utilization of these food referral programs looks like. This is the particular gap that this study seeks to address, and it will help identify factors that may be able to be tailored to improve uptake of these food referral programs, as well as their scalability and sustainability. The specific food referral program under investigation in this study is the Mid-Ohio Pharmacy. The Mid-Ohio Pharmacy is a partnership between the Mid-Ohio Food Collective, a large regional food bank, and the Ohio State University Wexner Medical Center, an academic medical center. The goal of the Mid-Ohio Pharmacy is to address food insecurity by screening and referring patients to fresh produce at a food pantry near their home. OSU WMC initially offered the Mid-Ohio Pharmacy at 2 family medicine clinics. The program has since expanded to an additional maternal fetal medicine clinic, 2 general internal medicine clinics, and 4 endocrinology clinics. But the focus of this study is just those 2 family medicine clinics. Patients that are referred to the Mid-Ohio Pharmacy are able to access fresh produce on a weekly basis rather than on a monthly basis at any one of 16 participating food pantries in the region. So the methods for our particular study included all patients that were referred to the Mid-Ohio Pharmacy between September 2019 through to November 2020 were eligible for inclusion in our study. Patients that were specifically eligible were those that received a referral if they screened positive for food insecurity, were at least 18 years of age, and had an eligible chronic condition. Screening used the 2-question hunger vital sign food insecurity risk screening questions. One of the key features of the Mid-Ohio Pharmacy is its ability to connect information between the Mid-Ohio Food Collective and OSU WMC. But to do this, patients had to sign a release of information to allow for their protected health information about the referral to be transferred, but from the OSU WMC to the Mid-Ohio Food Collective. We then used a unique identifier to match data from OSU WMC's electronic health record to the Mid-Ohio Food Collective's data system, which is called FreshTrack. FreshTrack records information at the food pantries about utilization of the food pantries. The FreshTrack data also gives us historical data about food pantry utilization. So we're able to examine not only use of the food referral, but also we can characterize patients as new to the food pantries or existing food pantry utilizers. And in addition, compare pre-referral utilization and post-referral utilization amongst those existing utilizers. So moving into our results, in total, 322 patients received a Mid-Ohio Pharmacy referral, and 164 of them, or 51%, visited a food pantry at least once following their referral. This slide shows a forest plot of patient factors and their association with visiting a food pantry at least once. We can see that a one-year increase in age, diabetes diagnosis, or being an existing food pantry utilizer increased the likelihood of visiting a food pantry following a referral. Patients, on the other hand, with uncontrolled hypertension were less likely to visit a food pantry prior to their referral. In a comparison of utilization between patients that had not previously visited the food pantries to those that were existing food pantry utilizers, we found that new visitors took longer to visit following their referral, traveled further than existing visitors, and had fewer total visits within 90 days following their referral than those that were existing visitors. There was actually, though, no difference in the number of visits that were primarily produce visits, suggesting that patients that use the pantries to address their overall food needs rather than just access produce. Just as a note, patient choice is really an important part of the Mid-Ohio Pharmacy program. So while patients are encouraged to select produce and are eligible to receive it, they are not limited to just acquiring produce from the pantries. So not all visits post-referral are by definition produce visits. So 81 patients in our sample had been existing pantry utilizers and had at least 90 days of post-referral data in our data set. So when we compared their use prior to their referral and then following their referral, we found that they had an increased total number of visits as well as an increased number of produce visits following the referral. As far as kind of how this broke down across time, particularly in the window from 30 to 60 days post-referral relative to 30 to 60 days prior to the referral, that's when kind of this increase in visit number really occurred. I think one of the most notable takeaways of our study is that prior pantry use is the most influential factor affecting post-referral use of the pantries. Prior pantry users may have pantries located more conveniently to them or may feel more comfortable accessing the pantries. However, the referral appears to act as a nudge or a reminder to use the pantries to the patients that are already in the system. This might be because the clinician is using the opportunity to discuss healthy eating with their patient, or the fact that the referral is coming from the healthcare provider reminds the patients that there is a connection between food and health. Our findings also suggest that other non-medical health-related social needs may be inhibiting use, such as transportation issues. Some food pantries are able to provide more comprehensive services and can address multiple social needs. And there are other models out there, such as the community hub model, that can offer these services. But I think it's critical to support use of these kind of more holistic approaches to addressing social needs that aren't addressing just a single standalone issue, but are addressing the co-occurrence of these social needs. A third takeaway from our study is that patients may use the food pantries for food generally rather than produce specifically, as the program was originally intended. This is not necessarily a bad outcome, though it is somewhat unexpected. There are likely a lot of indirect benefits from increased access to food in general, and this might help the program reduce food insecurity status. This could also be an artifact of COVID. Our study did span the COVID time period, and during COVID, many of the food pantries had to change the way they operate and the way patients are allowed to access and select certain food, and they may have had different selection of foods during different time periods throughout the pandemic. So how do we move forward and further support utilization of food referral programs such as this one? Our findings that prior users are more likely to continue to use the pantries following their referral suggest that there's a tension between focusing on this particular part of the population, which is maybe smaller and somewhat self-selecting group that is already engaged with the food pantries, rather than a more broader, more difficult group, the non-users or those that aren't already in the system. The latter group might require some changes to the Mid-Ohio Pharmacy program in order to reach them. One approach is to add questions into the screening process that help identify other support that might be needed to access the pantries, such as transportation issues. Still yet, the healthcare provider could provide text message reminders to access these services and use this program. Our approach to our efforts moving forward is also very community-oriented and community-based, and utilizes community-based participatory research to identify future directions and opportunities with the program, including qualitative research and stakeholder advisory boards to support how we tailor and refine the program. The utilization patterns identified in our study suggest that MOF can be helpful in connecting food insecure patients to these community food resources, but that achieving the health outcomes associated with that is going to take more time and potentially program modifications. Thank you very much, and I look forward to questions.
Wow, you all, this was so powerful. And when I talk a lot about health equity, I talk about it in the tree metaphor, or the analogy of a tree. And so thinking about the leaves as our health outcomes, the roots of those trees being everything from health access to the food systems that you were talking about, Daniel, and then the soil of that tree, really those structural determinants of health, Randy, that you've touched on. So I just want to end with one question for each of you all before we might have some from the audience here. But if you were thinking about, and Daniel, you touched on it with saying the agency of the participants, or those who were attending the food pharmacy, their ability to choose which food that they wanted. So what is a purposeful and directed change management strategy that you feel is needed to drive system transformation? There's so many ways we could enter into this, but I loved, Daniel, how you talked about those who are closest to the problem having some of the answers. And so I'm curious from each of you, if you just take some time to answer, what is a purposeful and directed change management system, or change management process for our system transformation that's needed?
Yeah, that's a great point and a great question. Thank you. I think that when I think about patient choice and patient agency in this process, I think it's thinking about this idea of partnerships, and this is not a dyadic issue. It's not just patient and provider, and it's patient and provider and community-based organization. It's everybody coming to the table for these joint solutions. And I think part of the issue is looking at these problems kind of in silos. And it's so what I mean by that is, it's the patient, it's the referral, the structure needs to be in place to make that referral happen. But then beyond that, there needs to be education about how to use those resources and maximize their benefit for health. There needs to be those coordinated approaches to addressing other co-occurring non-medical health-related social needs. And I think that there needs to be support for the patient moving along kind of that care continuum. And then going up a level, there also needs to be payment systems in place to support these types of programs, that in how they are reimbursed and how they exist, and how they can be supported in terms of aligning goals of all these different stakeholders. So I think that when I think about it, I think about partnership, and I think about it very broadly about partnership.
How about for you, Eileen?
Well, a couple things that come to my mind. I think one thing is that sometimes the desire to address all the social determinants of health, or all the social needs of your patients' populations, is there, but it's also ambitious and challenging. And I would encourage healthcare to look for any door in, if that's through. There's a lot of movement around addressing food insecurity and partnerships with food banks. And that feels like a place that really healthcare can get started. And there are active partners in the community that while they are not as well-resourced as they need to be, they are more well-resourced in a lot of cases than other potential partners, like housing and other needs that are maybe a little bit more difficult to take on. And so looking for those opportunities, and even if it's just addressing one, even if you know that there are many others that your patients need, there can be benefit in just starting to build those partnerships. And then the second thing is, I think for healthcare to enter this work with a recognition that the expertise is outside of healthcare, and really get to know those community partners and what their challenges are and what their the basis of the work that they're doing, the evidence that's already been collected around the work that they're doing and how they operate. So coming there with that humility and recognition that that you are not the experts in addressing social needs, but that you can be a facilitator to help your patients get those needs met.
Great, and I know we're going to have to wrap here shortly, but I just love maybe a word or two from Catherine and Randy.
Great, thank you. I agree with both of those sentiments, and I think the idea of thinking about it as a larger system and having the structures in terms of the payment mechanisms and relationships with payers, relationships with health systems and community-based organizations is just so important to really have all the right pieces in that partnership. And then really echoing on what Daniel was saying, as well as having the patient be the center of that and the kind of engagement and advocacy for patient agency and choice in this that I think is so important.
Yeah, I absolutely echo all of the sentiments that have been stated here today. And I think really what it leaves me with is trying to understand how and recognizing how our healthcare systems are part of the broader social world, that they're not separate from them. That being part of that broader social world also means that we have to train clinicians to engage. And also, I think the switch from cultural competency to structural competency and the other lessons we've learned today really drive home the point that I think it's important we critically reflect on kind of where we're coming from. That way we don't reproduce those same problems in the future. So I think as we begin to think structurally, I think it requires a kind of really digging in. So thank you.
Thank you all. I can't wait to dig in with hopefully you each in the future. And there were 20 contributors that made up this session today. So thank you all.